In the interest of time, let's go ahead and get started. So welcome to the first of 3 of our national webinars on Doxy PEP. I am Kimberly Taylor. I'm a project specialist with the Denver PTC. Today, we're going to be hearing from 3 of our clinical faculty, Dr. Megan Whitfield, a clinical faculty of the Southeast Prevention Training Center, Dr. Joseph Cherby, the medical director of the St. Louis STI HIV Prevention Training Center, and Dr. Karen Wendell, our medical director of the Denver Prevention Training Center. There'll be a few minutes at the end of the webinar for a Q&A session, so please go ahead and use that Q&A function to ask your question. I'm going to quickly go over a few admin items in the next couple of slides and then pass it over to our clinical faculty for the content. And we will be recording this webinar, and everyone who's joining here today will have access to the recording in a few days. All right, so this webinar is being put on by the NNPTC, or National Network of STD Clinical Prevention Training Centers. The NNPTC is made up of 8 regional prevention training centers known as the PTCs. Each state and territory has an assigned prevention training center, as indicated on the map on this slide. The PTCs are a resource for clinical training, consultation, and provision of tools and technical assistance to enhance STI and HIV prevention services. And in addition to the services I already mentioned, there are many resources that the PTCs can offer, but the next 3 slides are 3 we'd like to highlight. The first being the National STD Curriculum. It's composed of 7 online self-paced modules addressing the diagnosis, treatment, and prevention of STIs. Free continuing education is offered. This is a great learning group tool for healthcare entities to enroll their staff, assign modules, and track progress. The STI Treatment Guide mobile app is a really handy tool to have on your phone or someplace easy to access in clinic. It's a quick reference for looking at best practice and appropriate treatments. You can feel free to download actually today. If you point your phone at the screen and you scan that QR code, it will take you to the direct link to download this app. And finally, you'll want to bookmark the STD Clinical Consultation Network, or STD-CCN website. This is where you can ask an expert a tough question about clinical cases, or have help in finding a particular resource. So your consult, when you submit it, gets triaged to one of our staff, and then one of our attending physicians in your respective prevention training centers will respond to your question in 3 to 5 business days. So we are offering continuing education for this webinar today. So CE is going to be obtained through the CDC Train system. This is a separate system from your registration that you use to log on today. So instructions for completing the evaluation and obtaining that continuing education will be emailed to you after the webinar. And the deadline for obtaining the CE is 1 month from today, or 30 days, November 24th, 2024. And in compliance with our continuing education requirements, here are disclosure statements. I won't read through them all, but this is in compliance with our CE accreditors. And that is all I have for my slides. I'm going to pass it over to our first clinical faculty, Dr. Megan Whitfield.
Hi, and good afternoon and good morning to everybody. We're going to start today, what we're talking about today is Doxy PEP clinical update, and I will be speaking first. I'm Megan, and then Dr. Cherby will go after that, and then Dr. Wendell. Next slide is fine. Thank you. Our objectives for today are to review the data supporting Doxy PEP, highlight the CDC Doxy PEP guidelines, discuss some implementation successes and some challenges, which we think will be really helpful for everybody in their clinical practice, and to review the protocols and then some implementation tools that can be used in your clinic to just make this easier and to train other staff. And then we have a couple of case discussions at the end, which will also be more helpful for like real world scenarios. So let's talk about what Doxy PEP is. Doxy PEP is doxycycline, this post-exposure prophylaxis for sexual activity. This is a well-known antibiotic. We use this fairly commonly for lots of different types of infections, currently used for chlamydia treatment. It's part of the treatment guidelines for syphilis. not a primary treatment option, but it is there as an option. So it's well known to us. It was first studied in France with the iBrigade trial that was back in around 2015. We're going to talk about that trial a little bit more in just a second. It's a 200 milligram dose of doxycycline that is taken within 72 hours of sexual activity. So it's post the sexual activity. It's not pre. And there's been a new tool over the last 5 years to help reducing rates of STIs. The data is new, studies are still ongoing. We're going to talk about some of the most recent data that's been coming out, real world data, and where sort of new studies could be focused, or new data where more data is needed. There are proposed guidelines for this by the CDC in October of 23. We were kind of waiting on those for a little bit and happy to see them. And the full guidelines were released in June of 2024. So really helpful information, and we will get to that as well, talking about what those guidelines are from the CDC. Next, please. So this is a poll for the audience, just to kind of see, we wanted to see from you all kind of how to direct this discussion a little bit further. Is your organization offering Doxy PEP with an answer being yes, or no, but we're planning to start, no, but maybe in the future, or we're unsure, or your organization doesn't provide clinical services? So we'll just give everybody a second to answer that.
Yeah, answers are coming in fast.
Great.
I'm gonna give folks maybe about 15 more seconds here to answer, and then I can show you what folks have said.
Wonderful.
Okay, here are our results.
Awesome. Okay. So vast majority that are here are offering Doxy PEP. So hopefully we can just give you some more data to talk with your patients about, or if you're not really sure what the statistics were, then you'll have more data to. Sometimes this is going to come a shared decision making with your patient, and so then you'll have some statistics to give them, or just sort of real world information to give them. For people that are here that are not offering, or they can't, I'm sorry, but at least you'll know more about it. Maybe it'll come up in conversation, or you can offer it going forward in the future. Next slide, please. So this very first slide, or this slide here, is talking about that iBrigade study that was done or completed back in 2015, I believe it was, or maybe it was completed in 2016. This was a pretty large study. It was a number of about 400 people. It was completed in France. They were followed for about 9 months. You can see in the data here, which might be a little small on your screen, but the red line is no PEP, so no Doxy PEP. And the blue line is Doxy PEP. The endpoint on this particular statistic on this slide is a new STI. So this is going to be including gonorrhea in the statistic. So when you do that, when you include that gonorrhea in the statistics here, it's about a 50% reduction in overall STI rates in the Doxy PEP group. If you take gonorrhea out of the statistics, and there was about a 70% reduction in risk for chlamydia specifically, and then 73% for syphilis in the PEP group. Now, the follow-up window, something to keep in mind is that the follow-up window for this study was fairly short, with 9 months. Also to consider is that gonorrhea isolates are very predictably resistant to tetracycline in France. So could have impacted that data there just a little bit, but this was kind of what kicked everything off. So quite helpful. Doxy PEP was quite helpful at reducing rates of chlamydia and syphilis, not so much with gonorrhea. Next slide, please. And I apologize, y'all. I had notes on my slides, but since I'm not advancing them, I'm looking down at them just a little bit with all these statistics. So please bear with me. This one is probably a little harder for you to see. What I want you to kind of take home here is this is a study by Hazer et al. And it really starts to sort of break down the different studies that have already been done that are going to show you the same statistic kind of over and over again with great reduction in patients or people taking Doxy PEP, great reduction in their rates of chlamydia and syphilis. So the very first one here at the top is a study by Bolin et al. It was a fairly small sample size, but just know that there's about a 73% risk reduction for STIs amongst persons living with HIV that were taking Doxy PEP. The third study down, I believe, is the Doxy PEP study by Luckmeyer. I'm so sorry, I might not be saying that correctly very well at all. But they used the endpoint of time until new STI diagnosis and overall showed about a 60% reduction in the risk of STI at follow-up amongst the patients that were taking Doxy PEP. The DoxyVac study that's down at the bottom there had a really impressive statistical analysis towards the end, and I think that was because partly because they left gonorrhea out of the statistics. So they did not include gonorrhea in their endpoint statistics, and that is likely what impacted those rates there, where you can see per person years goes from 35, I believe, down to, I can't see that either, 5.6, I believe. So that's, if you would like to look at these studies, please do, but it's the same statistic basically over and over again, quite effective in people that were assigned male at birth at reducing rates of chlamydia and syphilis. Next slide, please. So let's talk about something a little different here. So people that were assigned female at birth, and let's define that just a little bit. So that's going to be our cis women, our trans men, our non-binary persons that maybe that have vaginas. So this was a study that was done in Kenya. It was a large sample size. The statistics here are a little messy to look at as well, and that's honestly what they were. There was no statistical difference in STI acquisition by the persons taking Doxy PEP versus the standard of care. However, this was people that assigned female at birth. They showed from some hair samples that maybe their overall use of the Doxy PEP was quite low. There were unfortunately about 4 social harms that happened during this study as well, with when people, when their partners found out about them taking Doxy PEP, there was a sort of violence between partners or safety concerns there. So that's unfortunate. And then there's also concern ongoing for just doxycycline use during pregnancy, which I'll talk about again in just a second as well. So this study may have been impacted by utilization, or it may have been impacted by people not knowing or not really having a good understanding of when they should use their Doxy PEP. So this study was not super reassuring for people assigned female at birth for the use of Doxy PEP. Next slide, please. However, some more recent data coming out. This is a data set that was presented by Jason Zucker. I did borrow this from Dr. Shereby, so I appreciate it so much. But it's a small data set, but it's showing something to kind of continue to think about in people that were assigned female at birth, where if these patients were already taking HIV PrEP, and we were able to decrease their STI diagnosis down by like half. So that's just something to think about, that maybe, it's like a shared decision making sometimes with some patients. And then next slide, please. Or we consider the delivery, a change in delivery of how doxycycline is provided to our patients that have vaginas. So this is a small sample size of 40 on this particular study, and this is a change in delivery. So instead of doing Doxy PEP, now we're talking about Doxy for PrEP. So this was a 100 milligram daily doxycycline dose that was administered to female or assigned female at birth sex workers in Tokyo. Their data endpoint was time to initial STI, and it was reduced from 232 to 79 per 100 person years. So quite a reduction in overall STI rates at their follow-up visits. And they did have STI testing in a range from every 1 to 3 months. Look at their syphilis rates. They go down to 0. So 0 incidences of syphilis during this study, which is wonderful, particularly amongst this population. There was a marginally significant reduction in chlamydia rates, but no change in the gonorrhea rates again with this. So just to be of note here, the side effects, it was tolerated quite well. The side effects were minimal, and no change in incidence actually of bacterial vaginosis or yeast infections, vulvovaginal candidiasis in these patients, which is also good to note. They did report good adherence. So they did a survey post, and about 50% of the participants did fill out the survey. So they did take their medication pretty predictably and routinely. Things to consider going forward are, again, the pregnancy risk with people that are assigned female, people that are AFAB. Their pregnancy risk is there. And so do we want, to use doxycycline and people where pregnancy could be a risk is something just to consider and discuss with your patient. And there's also some more studies upcoming with this. The Adolescent Trials Network has a study planned for 2025 that will include cisgender women in the United States that have a history of an STI in the last 12 months. So more data is up and coming. Next slide, please. So let's think about real world sort of behaviors and how this is used. So overall themes from a data review done by Frederickson, actually I think it was a behavior report, show that overall people found Doxy PEP to be reasonable. They found it improved their quality of life, and it did impact some sex behaviors for some, which we've kind of found with PrEP as well. Sometimes it does impact people's behaviors, sometimes it doesn't. But either way, it's been acceptable. It's effective and easy. It's eased their anxieties, and they felt more in control of their sex life. And who wouldn't want that? So overall, people appreciate it and find it to be reasonable and effective. Next slide, please. Some other real-world behaviors. This is a study by Zucker et al. That collected the behaviors and practices of about 87 individuals that were using Doxy PEP. They reported that they used it about 79% of the time. They didn't use Doxy PEP after sex when they determined their exposure risk to be low. So what this overall slide is telling you is that sometimes when people are having sex, they don't use Doxy PEP when they feel the sex that they're having is with one of their usual partners, or they feel like maybe they're using a barrier, or whatever reason that they feel like they don't use the Doxy PEP. And you know what? They're getting it right. So they're doing a good job. STI acquisition was actually pretty similar between groups that were using Doxy PEP more or less than 75% of the time. So the people that are using it every single time versus the people that are choosing when they want to use it are actually pretty similar. So that's then this some other data is the study that's at the bottom there out of the University of California, San Francisco, where they reported that HIV positive people randomly assigned to take Doxy after sex saw a 74% reduction in chlamydia and 77% decrease in syphilis and 57% reduction in gonorrhea compared with standard of care. And those rates were sustained so into the next year. So it's this that Doxy PEP it sustains those rates of lower STIs. So that's what we're seeing statistically. Next slide, please. Further with that data, so San Francisco has had like a fast rollout program that they've been doing of Doxy PEP, and they have seen statistically they're seeing an impact of that. So there's been no decline in citywide gonorrhea cases in men that have sex with men, but there's been a great decrease in the rates of chlamydia and syphilis amongst that population. On the flip side of that, their rates of chlamydia are actually increasing in cis women, and that is because the rollout was not specifically targeting cis females. So that's just showing you that their chlamydia rates are actually increasing around in that area, but amongst the population that is being targeted and has a faster uptake of Doxy PEP or having decreased rates of chlamydia and syphilis. Next slide, please. So some points to ponder. The effect on the GI microbiome is not known at this point. It seems to be okay. Definitely more studies are needed in the AFAB population. The long-term use looks to be okay. I mean, we already use doxycycline and other tetracyclines for long-term use, and it seems to go pretty well. But there are of course studies ongoing about antibiotic resistance and bacterial resistance. We've already know that gonorrhea has got tetracycline resistance, and we do think it may have increased a bit. And amongst people that already had Staph aureus in a nasal swabs, they were colonized. They did have increased rates of tetracycline resistance amongst that Staph aureus at a 12-month interval. But do with that what you want. There's no increase in MRSA resistance so far, and Neisseria so far. And then no tetracycline resistance found amongst chlamydia or syphilis bacteria so far. So that's where that is, but there's still data needed, still more studies needed on that point in particular on antibiotic resistance, but definitely need more studies for sure. Next slide, please. So the CDC guidelines right now recommend using Doxy PEP in a targeted population. So MSM, bisexual, trans female patients that have been diagnosed with an STI in the past year. However, there's room there to consider recommending Doxy PEP in the same population if there's not a recent STI diagnosis. There's also room for shared decision-making amongst your patients that are AFAB, trans men or heterosexual men, and I do think that's definitely worth consideration. Overall, we have to look at our patients and people that we're talking to in counseling and take a comprehensive sexual health approach including, frequent STI screenings, pregnancy prevention discussions, vaccinations, HPV vaccinations, linkage to PrEP, HIV testing, all of the above. So those are the guidelines and recommendations from the CDC. Next slide, please. All right, so then we have another poll, and then I will hand it over to Dr. Cherby. What are your biggest concerns with implementing Doxy PEP? So we're just kind of looking for maybe some chats here.
Yeah, let's go ahead and put your answer to this poll in the chat. This will go to our panelists and I'll kind of read out what folks are saying. Impact on microbiome, adherence, resistance, cost, compliance, inequitable pregnancy, antibiotic resistance. Sorry, they're coming in fast.
They are. There's a lot of them, which is great.
Yeah, and I see some things about AFAB and equitable distribution,
Mhm.
and I think we're gonna cover a little bit more of that in just a second as well. But yes, that's definitely a concern. The microbiome, I think, is going to be something everybody's just keeping an eye on, and resistance, bacterial resistance, everybody will just be keeping an eye on for sure. I will pass it over.
Awesome. Thank you so much, Dr. Whitfield. That was okay. That's like a world record in how quickly and efficiently someone was able to discuss DoxyPEP. So I really appreciate all of the feedback, and I love all of the input that everybody is saying with respect to their concerns as well as what they think might be challenges in implementing DoxyPEP. So for those of you who don't know me, Joseph Cherby, I use they, he pronouns, and I get the fun part where I get to talk about DoxyPEP implementation opportunities and challenges. So next slide, please. So just in case, some context for you all, in case you don't know where I work at Washington University in St. Louis. We're rebranding as WashU now. But I work in an academic medical center as well as the St. Louis County Health Department. So the reason I bring this up is because our implementation had to slightly differ across these two different contexts, right? So an academic medical center, oftentimes our patients are more insured. They are more linked into care. Whereas in our county health department, this is a no-cost clinic. So then we start talking about things like how often do we get people in? Who's going to pay for it? Is the patient going to be able to afford it? Et cetera, et cetera. And so there are a lot of different things that we had to talk through as a team in order to make sure that we were able to implement DoxyPEP in an equitable fashion. And I really appreciated what people were saying in the chat about equity, because equity is one of the things that we learned from HIV PrEP that was not implemented properly or equitably, right? Or equally. So what I mean by that is we know that HIV PrEP uptake is around 80% amongst white MSM. For Black MSM, it just passed 10%, right? And so we haven't seen this equitable implementation. And our fear is that with DoxyPEP, we might see the same issues. So what did we do? We basically got a DoxyPEP champion in our STI group. That was for us, Dr. Donald Hong, who we were like, okay, you're going to help in implementing this. You're going to take this on, and any questions with respect to DoxyPEP goes to this person, and the rest of us would help with that. And then the next questions were who, what, when, where, and why. And so with that in mind, we're going to go through each and every one of these questions and what we went through in St. Louis to try to get these questions answered. So let's start with who. Next slide, please. To give a perfect example of who may benefit and what issues there were, uh, I love this case. So I want you all to chime in on this case, which is one of the first cases that we saw with respect to DoxyPEP. And so this was a 37-year-old MSM who presented for HIV PrEP appointment and inquired about DoxyPEP. His doctor said that he hadn't had an STI in the last year, so wouldn't qualify for DoxyPEP, and that the risk outweighs the benefit. So what do you all feel about this? How are you feeling about this case in this scenario? Do you think that the doctor did a good job in this case? Provider education was needed. Yes. All right. So how would you educate the provider? defer to the patient's goals and requests, more sexual history. The provider flopped a little bit, just a little bit. Um, so I will say that this was a trainee, so we'll give our trainee a little bit of slack here. But the thing is that I like what people are saying that they want more sexual history. And the thing is that most of the time in sexual health and in terms of guidelines and recommendations, we're working in the past, right? We try to think, oh my God, like have these patients had an STI in the last year? Have they had multiple partners in the last year? But we don't oftentimes think in the future either. And when I say that, I mean, we don't think about who may benefit from it if they, for example, decide to have new sexual partners in the future. And if they decide that they want to open up their relationship or their sex partner has sex partners, et cetera, et cetera. So shared decision making, getting a good sexual history, finding out who may benefit from it, and ultimately doing some sexual health goal setting with each and every one of our patients is the goal. And I think Doxy PEP fits very well into that toolkit. Next slide, please. So this was the STI treatment guidelines. These were the populations that Dr. Whitfield already shared, but I just want to highlight one thing here is that the CDC recommends providers should counsel gay, bisexual, and other MSM and transgender women with a history of at least one bacterial STI. Although not directly assessed in trials, doxypep could be discussed using a shared decision-making approach with MSM and transgender women who have not had bacterial STI diagnosed within the previous year. I love that because it means that we get to discuss with our patients and our patients get to determine what's best for them. And I love shared decision making because it means that we are combating gatekeeping and we are combating all of the other obstacles that our patients may face in trying to get us to meet them where their sexual health needs are. Next slide, please. So with shared decision making, our goal as providers is to provide information to make an informed decision. And sometimes that means saying that we actually don't have evidence on this yet, that the evidence that we do have may be a little bit flawed. For example, the DPEP trial in Kenya showed that, doxypep didn't necessarily work in cisgender women, but when they examined hair samples in that very study, they showed that around 20% of patients who said they were taking doxypep actually took it. So we don't have data, and that's okay. But we can go through the pros and cons. We can discuss the benefits and that it could greatly reduce the likelihood of you acquiring syphilis, chlamydia, especially, and sometimes gonorrhea. But there also are side effects and risks. Some people do develop gastroesophageal complaints. They could develop photosensitivity. There could be diarrhea. And a wide variety of different things. So I go over this with each and every one of my patients. I say, this is what doxypep is. You would take 2 pills within 24 to 72 hours after having sex. Most often, we tell people to take it with a full glass of water, sit up for 30 minutes, or else you could get esophagitis. Some people get some GI complaints and it makes their tummy hurt a little bit. And some people get diarrhea. Some people could develop a rash or an allergy. And if you're going to spend a lot of time out in the sun and take doxypep frequently, we highly recommend some sunscreen. If you are AFAB or a transgender man or in any of these other populations where we don't have data, we don't have data yet, but there is no reason why it necessarily shouldn't work considering the pharmacokinetics and pharmacodynamics of doxycycline work within these various populations, and we use it for treatment. And so discuss all those benefits and risks, and then say, what would you like to do? Considering you've gotten all of this information, do you feel comfortable taking doxypep, and do you think you could benefit from doxypep? Allow the patient to make the choice and avoid gatekeeping as much as possible. Next slide, please. So the what is, as I said, doxycycline 200 milligrams PO once within 24 to 72 hours after sex. Seems simple, right? But then the questions start arising. Do we give 2 pills of 100 milligrams? Do we give 1 pill of 200 milligrams? What type of pills do we give? Do we give capsules or tablets? Do we give hyclate or monohydrate? Is there any difference between them? How many tablets? 30 tablets, 60 tablets, 120 tablets? And the answer is we've seen all of these, right? And so there is no difference between hyclate and monohydrate. I want to state that. When it comes to the dosing, oftentimes I recommend looking at the cost of the specific pills and seeing what is the most cost efficient way of doing that. Especially if you're working in a health department, you really want to be cost conscious here. And oftentimes I would just use the doxycycline that you already have in stock, and working around that. So if that's 100 milligram pills, then making sure that you recommend giving two 100 milligram pills instead of the one 200 milligram pills. Some patients report feeling a little less GI discomfort with tablets compared to capsules. Again, I leave that for the patient to decide. If they report some nausea with it, I may try the opposite of what they currently got. And then with respect to how many tablets, I highly recommend you speak with your clinical staff. Our NPs in our sexual health clinic were saying that they didn't want to refill every single 30 days or so. They wanted to have the patient have a little bit there, but also they wanted to be able to get the patient, they wanted the patients to have enough pills, but they wanted the patients to be able to come in frequently enough to get tested regularly. And what we're recommending is similar to the schedule that we use for HIV PrEP, which is once every 3 months. So again, discuss the cost and source of payment with your administration when you're trying to make these plans and see who's going to pay for it. Next slide, please. When to take it? After sex, duh. But the point is that how soon after sex should you take it? Within 24 to 72 hours is ideal. And you don't want to take more than 200 milligrams every 24 hours. And I say that because if you're having multiple sexual encounters within 24 hours, you're just going to take it once after, ideally after 24 hours after your last sexual encounter. And I wouldn't take it after every sexual encounter. If you have sex on a daily basis, you could either take it daily, 200 milligrams, or every other day. Sometimes with my patients, I recommend just every other day so that they get a little bit of a break. But honestly, it's up to the patient to determine. And as we saw through the information from Zucker et al., oftentimes our patients are the experts in their own sex life and determining when they are at an increased likelihood of acquiring some of these STIs. Next slide, please. So this is just again showing the real world use and behaviors of Doxy PEP. I just wanted to delve a little bit deeper into some of the data that Dr. Whitfield shared, which is that 79% of individuals said that they didn't take Doxy PEP because they didn't think they were at risk for an STI. And the majority, 61%, said their encounter was with a regular partner, which we know is at a decreased likelihood of acquiring STIs. 24% said that they had sex with someone they expected to be STI negative. And this fits in line with what we're seeing in the real world. When you talk to your patients, they'll say, yeah, me and my sex partner recently got tested, so I felt a little bit more comfortable having condomless sex, right? 98% reported daily oral PrEP adherence, and 63% of on-demand users reported using it after sexual encounters. So the reason I bring this up is because there's similar rates between the on-demand PrEP use and Doxy PEP use, right? And we still see the effectiveness across both. And so through shared decision making and trying to see what works best for your patients and their sex lives, we're still seeing effect and effectiveness in terms of HIV transmission with HIV PrEP, as well as STI transmission acquisition in Doxy PEP. Next slide, please. So where can this be implemented? In other words, who's going to pay for it, right? And so when it comes to patient paying for it, I know that oftentimes $12 may seem like not much, but for many of our patients, that is a lot of money. And so I want you all to see what works for your patients and if they can actually afford this. If not, then honestly, working with your 340B funds, for example, if you're a 340B designated clinic, is very helpful, especially 340B STI clinic. As for, in our non-academic centers, or let's say in our sexual health clinics at our community health departments or local health departments, that's a cost that may have to be eaten by the clinic itself in discussing how best to implement this for your patients. I highly recommend working with a pharmacy that you trust and working with pharmacists that are well versed on STIs, as well as HIV care. And a pharmacy collaboration is worth its weight in gold. And then as for ICD-10 codes, I know that Karen is going to delve a little bit deeper into some of these protocols, but we like to use Z20.2 with respect to exposure to STIs. Next slide, please. And why ultimately is to decrease the rates of STIs. And I bring this here, I know it may sound straightforward, but we have to understand the state that we're currently in with respect to STIs, especially syphilis. We are seeing record rates of syphilis and continued increase in syphilis, right? And so we really want to zoom out a little bit and understand that implementing this does have real world effect, as we saw in San Francisco with their rates dropping and being a sustained drop as well. And we have to understand the similarities between HIV PrEP implementation and Doxy PEP implementation. We know that there's a large amount of stigma against condomless sex. And, the amount of times I hear people say, well, I don't want to promote unhealthy sexual behaviors or bad sexual behaviors. That's quite frequent. And that was the same thing we saw with the HIV PrEP. But the thing is that we're already giving this medication now. We're already giving it for acne, for malaria prophylaxis in a wide variety of different ways. And oftentimes patients or doctors don't feel super uncomfortable with that. So you may have to check for some biases here with respect to sexual health, which we know is quite frequent. Sometimes it's unconscious bias, but nonetheless, our goal here is to try to decrease the rates for each patient individually on their own and overall as a population too. Antimicrobial resistance is actively being looked at. Trust me, every single conference we go to, people are talking about antimicrobial resistance. But ultimately, we really want to combat sex negativity and be sex positive and create sexual health goals for each and every one of our patients. That starts with listening to our patients, what they want, what they need. And we know that DoxyPEP is something that the community very clearly is asking for and wants. Next slide, please. So future directions, Doxy PrEP. There's the syphilaxis as well as the DISCO trial. These are two of the best named trials I've ever heard in my life. There's also DoxyPEP and AFAB, antimicrobial resistance monitoring, of course, and DoxyPEP post-STI exposure and post-sexual assault, for example. And those are things that are actively being looked at by a variety of different groups. Next slide. And I hand over to my esteemed colleague, Dr. Karen Wendell.
So thanks. I'm going to spend some time talking about protocols and tools. And I want to stress that these really help not only our providers and our health care organizations implement DoxyPEP, but also help our patients. Next. So in talking about implementing a protocol, there are always pros and cons. Certainly, a protocol can help us offer education and counseling in a more routinized way to assure that we hit every patient who might benefit from something. And help us to routinize how we provide the service. In other words, how we dispense it, what kind of counseling we give to the patient about taking the medication. And we hope that with those types of routinized processes, we increase equity and decrease stigma, as Joe already talked about. But sometimes we miss people when we have a protocol, and it's an important thing to keep in mind that providers can become overly reliant on a protocol and miss fringe cases, and we're going to talk about some of those to come. And it may kind of limit how a provider customizes the service to a patient, and it shouldn't do that. And so when we implement a protocol, we do need to stress to people, just like guidelines, these are tools to help you, but don't mean that you have to do every single case in the same way, unless you're in a setting where that protocol is sort of part of a standing order. Next slide. So when thinking about protocol components, I think there are four main areas that I usually think about. One is, how do we implement this in a way that hits the patient population that we're trying to present it to? And I think that in thinking about DoxyPEP, there are many different areas of a patient encounter where you could think about inserting a protocol counseling message. And that can be in the patient intake component of a visit, during prevention counseling, during a sexual history, or incorporating it into certain types of visits and the documentation that goes into certain types of visits, such as HIV care, HIV PrEP, HIV PEP, and STI treatment visits. When we do have a protocol, we have inclusion and exclusion criteria that sometimes help guide providers, not only in thinking through when we're not going to be offering it, how we are going to be offering it, but what are relative contraindications or relative exclusion criteria. And then these protocols really help us provide more standardized and I think higher quality care in that they help us provide information in a format that is standardized and help us avoid forgetting to tell patients about certain aspects like calcium interactions with doxycycline. They help us with the prescription, so we're not entering each time how to take DoxyPEP into kind of a edited portion of a prescription, but rather it's pre-written in a way that is hopefully destigmatizing. We use the same ICD-10 code, and we have a way of thinking through how we dispense doxycycline in a particular setting. We think about in that way in the protocol, like Joe mentioned, if there's prescription coverage or not, and what that means to how much we can dispense. And then finally, we have in our heads already, based on this protocol, how we are going to handle doing refills. What's required to get a refill? What's the frequency of provider visits that are going to be a part of the care that we provide in association with DoxyPEP? And what is the requirement for completing STI and HIV testing when we're thinking of doing a refill? So having that in place not only helps our providers say, oh, before I fill this refill, I'm going to check when their last visit was, I'm going to check when their last STI and HIV testing was, I'm only going to refill to the designated interval that we have in our protocol. It helps complete that for a provider so that there's a standardization of how it's offered, but it also helps our patients understand, well, you know, when I reach that certain interval, I'm going to have to complete that STI and HIV testing. And I know that ahead of time, but I know that I can get refills and it is available to me. Next. So in thinking about creating your own protocol for your particular healthcare organization, we do recommend that you take a look at this tool that was designed by our partners in the Baltimore Prevention Training Center and is available on the NNPTC website. It can really help you think through making your protocol to fit your facility. Next. In thinking through the tools that become a part of your protocol, there are tools that are really patient-facing and tools that are more provider-facing. But one of the most important things is for us to try to avoid, as Joe was saying, that pitfall that we experienced in PrEP rollout for HIV. And to do that, I think we need to really enable and empower as many patients as we can. We need to get the word out in an equitable way. And so there are many tools that are available already on the NCSD website and also on our NNPTC website to help you do that. We can think about posting posters not only in our clinic, but in community-based organizations that serve the patients that we see most and think are might benefit from this intervention. We can have handouts available in those locations. We can automate delivery of messages about availability of DoxyPEP through our patient portals. And so we commonly do this in our clinic where we send out messages to certain populations within our patient cohort to make them aware of certain things like Mpox vaccination. And so we can automate a generalized message and send that out through our patient portal. And we can also in our healthcare organizations create posts in Instagram, Facebook, and X that really help get the word out to patients who visit those sites. And to help us in doing that, there's a bunch of media tools available through NCSD. And so you don't have to pay for instructional designer. There are media tools that are available that can be customized for your organization. And this increases patient awareness and brings them into care that they can benefit from. Next. When I think about provider tools, I am laser focused on EHRs. And so for us, it's Epic. And so you're going to see some examples from Epic here. But for any EHR, they can help us in so many ways. The first way that we think about this is how do we make this equitable and not just based on a provider going, oops, oh yeah, I need to talk to you about DoxyPEP. We want to make sure that a provider is triggered to provide that counseling whenever appropriate. So for us, we think about building that into certain components of the EHR. This is an example. So in our EHR, SOGI information is collected right up front during the intake for every patient. And we have associated with that DoxyPEP questions. And so that they can be used when appropriate in association with our SOGI tab to get that information out to everyone. Next. You can also use things like best practice alerts. Now, this particular best practice alert is not for DoxyPEP, but it's an example of how you can really hone in a best practice alert. So you can choose it to fire for certain criteria. An easy idea would be to have a BPA file for any patient who is receiving HIV care or HIV PrEP care, who has not got an active doxycycline prescription. And then the provider gets that message and has to click past it. The best BPAs we know are the ones that have easy access to the next steps that they would implement so that it really creates kind of opportunity for the provider instead of annoyance. And so when it pops up to have those next key steps of, the ICD-10 code, the prescription, and the counseling message. So things to consider when you're implementing in your organization to make sure that we don't fall into the trap of only providing Doxy PEP to the patients who bring it up to us. Next slide. Other tools that we can think about using are tools that help us with note templates, order templates, and really whole packages. So in Epic and in many EHRs, there's the ability to make sets of information. So for instance, for us, we have a smart set that includes the ICD-10 code. So you don't have to go, oh, what was that? Oh, what that? It's right there for you. You just click on it. And then the documentation pieces are available to assist you in documenting in your note and making it a quick documentation. We have the tests that you might want to be ordering on this patient, such as GCCT and syphilis and HIV antigen antibody tests if appropriate, the prescriptions that might come along with that, and then AVS counseling messages that you would want to include to the patient when you're providing Doxy PEP. So packaging that all together is going to help everyone provide the services in an equitable and high quality way and follow your protocol. So these tools really connect to your protocol and help people follow the protocol in an easy way. Next slide. And of course, you want to have that patient information available in multiple languages. For us, and it really is based on your patient cohort, for us, it's very important to have all of this information available in both English and Spanish. And so we're able to quickly put that in an after visit summary that the patient obviously can look at anytime because it's on the patient portal. And we have that ability to put it in as a dot phrase, in our case, for Epic in both English and Spanish. And it really routinizes the information that's provided to the patient and makes sure that it's complete. Next slide. So these are some examples of patient counseling tools. You don't have to invent this all over for yourself. I have one that's from NACHO and one that you can see that's more graphical, that's available on an NPTC site and was obtained through San Francisco City Clinic. Next slide. So examples of how we did this in the Denver Sexual Health Clinic, which is a public health clinic. We constructed a protocol that encompassed many of those tools in our EHR. We made visit types where patients can access Doxy PEP. And if they want Doxy PEP and don't need a visit, they can have a telehealth visit to start Doxy PEP. We included Doxy PEP in all of our rooming tabs. So frankly, every patient that comes to the clinic hears somewhat about Doxy PEP. And for those that are taking it, we assess their use and correctness of their use. And then we have tools to document our own notes and to provide that counseling message in the after visit summary. We have the order set up. And for us, when we're doing that doxycycline prescription, we have heard from clients, they don't want it to say after sex. They want it to say after exposure, just in case some of their housemates or family members find their prescription. And so we've standardized that into our order, and no one has to think about typing that out each time. It's available to the provider's standard. And then refill rules. For us, we are a sexual health clinic. We say that if you have STI and HIV testing, we'll refill you up to 4 months. Our CAB patients are only getting STI testing at 4 months if they're without symptoms. And so if they're going to go beyond that 4 months, we order their STI testing. They can come in and do that at any time, and then they're eligible for more refills. When we're calculating how much to give, for us, we're paying for many of our patients doxycycline, so we have a maximum allotment of 60 for our clinic patients. But what we try to do is ask them how many exposures they anticipate in a month, and then give them a refill that will last them to that 3 or 4 month follow-up visit with the provider. So that's how we've done it in our clinic. Next slide. And if you need more resources, you can find them both on the CDC, the NNPTC, and NCSD sites, and these are going to be available in the slides afterwards. Next slide. So we're hoping to discuss a couple cases. Next slide. Case 1 is a 32-year-old cisgender man who presents for STI screening. He requests Doxy PEP. He has 5 new partners in the last 2 months, no history of STIs, no condom use, methamphetamine use, but not other substances, and used PrEP for a year but stopped 2 years ago. Review of symptoms is negative. Next. So we want to hear from you what you think is the best thing to do for this patient. You order STIs and HIV testing, hepatitis C testing, and counsel on condom use. The patient is uninterested in HIV PrEP after discussion with you. What would you do next? A is decline doxycycline PEP since the patient has not had an STI in the last year. 2, provide Doxy PEP if the patient agrees to start HIV PrEP for optimal wellness outcomes. Or C, provide Doxy PEP with shared decision-making.
All right, Dr. Winderlow coming in fast. I'm going to give folks maybe 20 more seconds here, and then I'll share with you what folks are saying.
Someone play the Jeopardy theme.
Okay, let's see what folks are saying. Here's our results.
Oh, wow. Nice. Okay. Panelists, do you have anything to add? Or we'll move to the next case.
I love that everyone, the majority said through shared decision making, because this is one of those instances where once again the patient doesn't necessarily meet the guidelines per se, but is asking for it, and so they could very much benefit from it. And I think that having ongoing discussions and checking in every 3 to 4 months would be helpful for this patient. Awesome.
Terrific. Next case. And there was a question that came up in the chat, and I just wanted to say there was a question about how much DoxyPEP folks are using, and we have some data about that certainly. And for the DoxyPEP study that was done in San Francisco and Seattle, the median use was 4 doses, 200 milligrams a month, but about 15% were using over 20 doses a month. And so it is important to consider and discuss with the client about what that is going to look like. In the DoxyPEP study, on average, patients took about 43 additional days of antibiotics compared to what they would have taken without the DoxyPEP. Okay, so case 2, 46-year-old transgender man presents with acute on chronic pelvic pain and exam is compatible with PID. The patient has had 2 previous episodes of PID with positive tests for chlamydia and gonorrhea in the last year, 2 partners in the last year, occasional condom use, no substance use, and is on HIV PrEP and has a Nexplanon in place. Next. You order treatment for PID, counsel on condoms, discuss partner treatment, and order a follow-up STI screening in 3 months. The patient asks if there's anything else that they can do to prevent another case of PID. Would you discuss DoxyPEP and provide it with shared decision-making? Yes or no?
Okay, once again, coming in fast. Let's do about 20 more seconds for folks to answer, and then I'll share with you what folks are saying. Here's our results.
All right, I'm going to open it up to the panelists. Not a lot of controversy in our group.
Yeah, I think this comes back again to the shared decision making, and I'm so glad that the CDC has included that in part of the recommendations to be able to open it up to discussion with your patient. This is something I do see in my practice, and it is something we've come to a decision together. We discuss sort of the information as we have today, and come to a decision together for what to do. And I really appreciate also the real world data that shows where people are using this kind of judiciously or when they think it's appropriate, and they're doing a great job with that. So I think that's just another thing to add to sort of, elevate that shared decision-making discussion with your patient. But there's room for that. And I think in this case, that's a great thing. Even if you took the PID out and just said several cases of chlamydia or whatnot, that still would be a great conversation to have and very appropriate.
Guidelines are just that. They're there to help guide, but they're not written in stone. So I think this is a great example of that. I actually had a very similar case to this in which my NP was like, "Oh my God, did I do something wrong?" I was like, "No, did you do shared decision making?" She's like, "Yeah." I was like, "Great, fantastic. This is great. This is what we want to see." So it was really, really quite informative for her. But she really this idea of shared decision making, trying to figure out what works for the patients. This patient could definitely benefit from DoxyPEP, right? Considering their history. And so again, clearly stating we may not have all of the evidence in the world to help us with this, but it could help and benefit you. And again, going through the risks and the benefits and clearly documenting that is very helpful.
And I think we wanted to answer the last question in discussion.
Yeah. What do you think, Karen? I
Um,
know what I do. I want to see what you do as well.
So for gonorrhea, we absolutely do still treat as a contact because of the limited efficacy for us. It's got about 30% resistance in our population for tetracycline, so we still do provide it. For syphilis, we also are still providing it at this time until there's more data. For chlamydia, we offer the patient that they can be, if they took it after the event that they think was their exposure, they could just have retesting in about 2 weeks if they would like. And that's sort of how we're handling it at the moment. Joe?
Yeah, so I would also, I echo the exact same thing. With respect to chlamydia and syphilis, honestly, if it's an exposure, and they test negative for the syphilis part, if they have a negative RPR, no signs or symptoms, I'm fine giving DoxyPEP. And I know some colleagues have also done that, but again, syphilis is one of these things that we do want to take quite seriously. Chlamydia, on the other hand, I have given DoxyPEP as the treatment. And again, you have a 72-hour time window here, right? So like this isn't I'm just giving DoxyPEP 7 days after an exposure. This is DoxyPEP within 72 hours of an exposure is when I would give it, personally. But again, it's one of these questions we don't have a lot of data on, and you just want to make sure that you get close clinical follow-up. I loved Karen's suggestion of doing a test in 2 weeks if necessary, or even, I just want to make sure that get them back at most in 3 months just to make sure that we get them tested and get them linked into our system. Anything to add, Dr. Whitfield? Okay. There's a question about in the health department with standing orders, how do you accommodate these who fall outside the protocol but could benefit?
So for our particular clinic, there's a protocol that people follow. And then if they want to go outside the protocol, it has to have an attending approval, and the attending writes a note in association with it.
Great question.
But we have an attending on call in that clinic every day. So that might be different for different clinics. Any other questions? Throw them in.
We had one come in. What about DoxyPEP in alcohol intake?
I'm going to say I don't worry about it.
Yeah,
Everybody
me
else.
neither. It depends on how much alcohol. Also, practically speaking here, if you're taking DoxyPEP with the alcohol, you could get some gastroesophageal reflux and it's not going to make you feel really great. But I think a lot of the question and concern comes sometimes from long-term DoxyPEP use and some people getting elevated LFTs. But this is with long-term use and it's not very common. So I wouldn't worry too much about it, and it's not a contraindication.
Amazing. Yeah, we have about a minute left. We'd love to, if anyone else has any other questions for our panelists.
I'll just say for patients who are on Accutane, we are not providing DoxyPEP at this time.
Okay.
And I'm not sure about the DoxyPEP with transition, if you're meaning like HRT, but is that what was meant there with that question?
Which
It
question?
says any concerns with DoxyPEP and transition medication. There's no concern there as well, so.
Yeah.
No interaction.
If you're meaning HRT.
Yeah.
Okay, let's see. Okay, so a patient tells you that they have had an exposure to chlamydia from a sexual event 2 days ago. Do you provide the full treatment of chlamydia? I think DoxyPEP might be under treating it since it is up to 70 to 80% effective. Thoughts?
I'm fine with DoxyPEP personally, but like the reason why I say that is because you're going to, so let's be clear here. Let's see what type of exposure this is. If it is, if I'm worried about rectal, for example, I might do a full course. But like if it's just a simple exposure of urogenital, I'm fine with DoxyPEP. And also, most of the EPT studies have been looked at with exposure were from azithro 1 gram, right? And we know that that's slightly less effective than doxycycline. So again, we're finding out data as we go along. A lot of this is functioning in a gray area that we're just slowly getting more and more information on as we're implementing. I will remind you the guidelines just came out, right? So we're still gathering our wits about us and trying to figure out the answers to all these different scenarios. But I love that these are things that you all are thinking about because I think this is, these are some of the things that we want answers to and that we will be looking to get answers to in the near future.
I just want to mention, so there's a ask for an example of the standing orders with the slide presentation, all the slides from today, and then all the resources that all of our speakers have mentioned will be available to everyone in attendance. We'll be sending out a follow-up email with access to webinar recording, slides, and resources. So we'll be sending those out. Um, and let's see, panelists, any other questions we want to comment on? Okay, thank you all so much for attending. Thank you again for all our speakers, Dr. Whitfield, Dr. Jeremy, Dr. Wendell. We have 2 upcoming webinars as well. So we have an additional webinars at the end of the month, October 30th and also November 7th. I've just posted in the chat a direct link to register if you want to forward that on to colleagues who weren't able to attend today or you want to join yourself. There will be different representation from our different PTCs in those webinars, so feel free to join us then. And thank you again for joining us. Take care, all. Thank you.